Good day, I am Ziggy Amores and I am here to present a simulation video of the endotracheal tube intubation. The case is an elective laparoscopic cholecystectomy patient that was scheduled for surgery. After the patient was placed in NPO for 8 hours, IVF was started and wheeled into OR. The patient vital signs were the following: a blood pressure of 110/80 mmHg, a heart rate of 70 beats per minute, a respiratory rate of 12 cycles per minute, and an O2 saturation of 100%. Begin by assessing the patient. Look externally and assess the body habitus and the dentition. Evaluate the 3:3:2 rule. 3 finger breadths mouth opening, 3 finger breadths from the tip of the mentum to the hyoid bone, and 2 finger thyromental distance. Assessment of the malempathy classification is usually done in a sitting patient with the head in neutral position. After which, you hook the patient to a cardiac and pulse oximeter monitors, then maintain IV access for medications. Since the patient is hemodynamically stable and with no contraindications as stated by the case, we administer propofol and succinylcholine with the following dosage you can see from the screen. Materials needed for intubation are laryngoscope, bag valve mask, suction, endotracheal tube with stylet, 10 ml syringe, plaster, and stethoscope. Assume the sniffing position. You can do this by placing a towel at the occiput. Flex the neck while extending the atlanto-occipital joint. Suction for any secretions of blood. Then, perform the jaw thrust maneuver to move the tongue anteriorly. Pre-oxygenate using the bag valve mask. Use the AC hand grip. Ensure a tight seal. Manually bag with your right hand. Oropharyngeal airway may facilitate the airway patency in case of airway obstruction. Propofol and succinylcholine is then administered IV. Scissor your thumb and index finger to open the mouth. Hold the laryngoscope with your left hand and the blade may be near the finger for better position and control. Enter at the right corner of the mouth, then sweep the tongue towards the left. Advance the blade further until the vallecula. Lift the blade upwards towards the direction of the handle and avoid looking back using a wrist motion. Keep your wrist fixed and move your forearm. Once the vocal cords are seen, insert the endotracheal tube with stylet at the right side of the patient. The bevel must face left to facilitate better view of the vocal cords. Advance the tube until the cuff is 3 to 4 centimeters below the vocal cords. Then, remove the laryngoscope. Insert the cuff with 10 ml of air using the syringe to create a seal in the tracheal wall. Remove the stylet. Connect the patient to a breathing circuit, then check for the chest rise and fall and chest expansion. With the use of the stethoscope, use it to auscultate for equal breath sounds over the left and right intraclavicular, intramammary, and epigastrium. A capnograph measuring the end-tidal carbon dioxide can also be used. Lastly, secure the endotracheal tube with a plaster. Thank you for listening and good day.